Alright, can you hear me now? Okay, so again, I was saying if we allow epithelial cells to grow down into the defect, then what we get is healing by repair. Long temporal epithelium, very little bone formation, and probably very little regeneration of the periodontal apparatus. So the goals of I think I can understand why you want this. But let's just go back to the mind. Okay, all right. That's on that. Okay. Now, the ultimate goals of regenerative periodontal therapy is, of course, number one, we would like to achieve periodontal health, and of course, a clinical attachment level gain. And what would be nice is radiographic evidence of defect. Now, there's always been an argument going back and forth is whether that bone that you see formed a defect, is it actual regeneration or not? Is it just bone growing and filling up defect, or is there actual ligaments, cementum, and other bone forming? Now that unfortunately is a question for the ages, because the only way to confirm that is take a tooth out, section it to histology. But of course that's that's impossible in day-to-day practice. So for regenerative therapy, it's highly dependent on the surgical approach. The skill, the experience, as well as the biomaterial. Skills are acquired by knowledge and training. And we are always looking forward to doing less invasive protocols. We want smaller clamps, smaller incisions, shorter operating times, and this always leads to better outcomes in terms of patient mobility, in terms of surgical results. And what I have found was that the selection of biomaterials that I use does make a very big impact on the outcome of surgery, as well as my operating time. So since here we are here to talk about synthetic grafts, now are synthetic grafts advisable to be used in periodontal regeneration? Now as you know, synthetic grafts, you've got categories, ceramics versus polymers. Polymers are not mainstream synthetic materials used in dentistry, so what you probably would have come across were calcium phosphate grafts like HA, beta PCP, calcium sulfate, and bioactive glass. Now, of course, when it comes to the selection of material, we always look back into evidence. Now, in this Periodontal 2000 paper, it actually did a literature review on the biomaterials for promoting periodontal regeneration in human intrabony defects. And it looked at all that were available: xenografts, allografts, autogenous bone, biologically active factors, and of course, synthetics as well. Now, for a graft, an ideal graft material should be able to give you a good osteoconductive matrix, osteoinductive factors, as well as osteogenic cells. So the only one that fits that is autogenous bone. So why not we just forget about the rest and just use autogenous bone and be done with it? But unfortunately, like what Dr. Scott mentioned earlier, that's not always possible. Right? There are patient factors we need to consider. Are we able to harvest enough autogenous bone to prevent defect? And we have to think about the second surgical site and whether that actually increases patient mobility. So here, if you notice, alloplastic grafts don't seem to be doing quite well, right? So if you can take away anything from this paper, it would be that you are actually doing yourself a favor by staying away from synthetic grafts. And this is the kind of stereotype I had in my head as well. So when I was training as periodontist, we were always told to use, okay, just go to allografts, xenografts, and a membrane, and you can't go wrong. And results are good. So that's how I was trained, right? So, and it's not to say that you cannot use synthetics, but you're better off using something else, okay? Now, and the comments in the papers were always quite similar. It resolves too fast. It has poor regenerative outcome. And a lot of times you get fibrous encapsulation of the bone graft and the whole thing falls out. But what's important to note is these studies looked at single component synthetics. So we were talking about biphasic here, but this study was all single components. Either HA, calcium phosphate, beta PCB bioglass, HTR is a synthetic polymer. So these single component synthetic grafts, that's why the results showed as such. Right? It was not as good as the other graft materials. But now, currently, of course, we have got biphasic synthetics. So as was explained in the previous lecture, they are just a combination of two different components, It could be HA and beta PCP, beta PCP calcium sulfate as in EthOss, or HA and calcium sulfate. Now, prior to 2017, before EthOss was introduced in Malaysia, unfortunately, we only had single component synthetic grafts and one particular combination, which was HA and beta PCP, available in Malaysia. So when EthOss came in, it was actually somewhat of a game changer for us in terms of how the material was used in our surgeries. So these are some of the examples. Okay, I'll just quickly go through the next two slides. This was mostly covered in terms of available data for research. Now, in this paper published in 2016 by Dr. Raman, this showed, he looked at what was the osteoinductive potential of synthetic bone grafts when compared to the competitors. But in this case, it was a biphasic calcium phosphate graft. So it was HA and beta PCP combination. And what he found was at 3 weeks and 6 weeks, it was doing as well as an allograft. Okay, and his conclusion was that the scaffolds are able to induce ectopic bone formation without the use of osteoinductive growth factors. Right, and this was 2016. And as you mentioned earlier, like EthOss has actually been in the market for the past 10 years. Now, similarly, in papers going as far back as the mid-90s, orthopedic surgeons have been using biphasic synthetic grafts in their surgeries. And they have come to the conclusion that it has significantly higher regenerative potential, and the graft porosity develops. Now, the two materials that we use, they have different resorption profiles. Ideally, one resorbs faster than the other. So what you're left behind is a graft porosity that actually enables very early infiltration of blood vessels as well as cells into the material. And this is what contributes to the osteoconductive and osteoinductive properties of the material. So then we have EthOss. So in 2017, EthOss was launched in Malaysia. I started using it in 2018. And as Dr. Sun mentioned, it's made up of 65 and 35% components of beta PCP and calcium sulfate. And the results published were 50% new bone as early as 12 weeks. But the statement that caught my eye when I started using this material was this: an in situ hardening graft material, which means that negates the use of membrane. It precludes the use of membrane. You don't have to use membrane. Okay? So that actually made a difference in terms of myself treating infrabony defects. Because this is what I would conventionally do for guided tissue regeneration. The term guided tissue regeneration means that we're using a membrane to make sure to create a barrier to prevent epithelial cells from growing down into the defect. Okay? So in this case, this is the upper 6. So the defect is exposed, debrided, the graft material reused, in this case it was xenograft, and a membrane placed over it. Now, I can tell you that this entire surgery will take me about an hour and a half, an hour 45 minutes max, and the bulk of it goes to this. Trying to adapt and modify the membrane to make sure that it hugs the contours of the 6 and the 5, so that the bone graft doesn't leak out, and that takes a lot of time. Now, it is satisfying to do once you get the hang of it, but it does take time. Okay, and you can see that the extent of the flap is bigger. Now, we were taught that the collagen membrane has to extend 3 millimeters beyond the margins of the defect. So the flaps are big, both on the buccal as well as the palatal. But wait for 6 months, and the healing is there. You can see the graft, the defect fill, and of course, the reduction in probing depth. Okay? Now, GDR is actually a tried and tested method. Okay, and it has got significant results when compared to just open flap debridement in terms of pocket reduction as well as hard tissue formation seen upon re-entry. It does have some adverse effects which are generally minor, the main ones being early membrane exposure, which can be handled quite well as long as the infection doesn't set in. But the most often raised comment was it does take time. It does take longer chairside time when you compare with other simple procedures like open flap debridement. Now, that was one of the driving factors that actually drove researchers, particularly Dr. Cottolini, to come up with what's called the minimally invasive surgery, or the minimally invasive surgical technique. I'm sure you've heard of this. where he has taken treating infrapoly defects one step further to actually make it simpler, reduce chairside time, and reduce patient mobility. In these cases, the flaps and the incisions made are very, very small, and it comes to just the matter of raising the papilla over the defect, where the defect is. Okay? So you can see it's a very, very small flap. So obviously, when you open a flap like this, using a membrane is out of the question. You cannot adapt the membrane into that small space. Right? It's really difficult. And that's why quite often Dr. Tocklani uses enamel matrix derivatives to actually upregulate the host healing and to make sure the right kind of cells populate the infrapoly defect. And the result that he has shown is actually very impressive. Now, studies have shown that it has the potential to greatly improve the conditions of the sites when compared to the conventional surgical technique. And it's constantly associated with increased comfort for the patient, as well as, of course, a shorter chairside time if you were compare this to the previous study that I showed you. Okay? So this is where I sort of wanted to try EthOss in. Since, remember, the keyword was an in situ hardening graft material, no need membrane. So what if I put EthOss in there and then set? Right? I don't need to open the flap as big, I don't need to adapt the membrane. So just put it in there, let it set, close the flap. So can I use this with the minimally invasive surgical technique? Right? Now, enamel matrix derivatives separate. I mean, the results are good, but at least in Malaysia, there are two hurdles that we have to get past. Number one, it's expensive. And number two, because of its porcine origin, the use is a little limited, in my patients, right? So we were always looking at what else we actually put. We can probably put in a xenograft and allograft, but what's keeping it from leaking out through the sulcus? Because in this case, we can suture that across, but there is still the sulcus to contend with, and that's still a communication into the defect, right? Even how well you suture that thing tightly against the tooth, so the suture just goes right across the defect site. So this is where what I wanted to try and see whether EthOss works, if EthOss works in fragment defects. So I'd like to share some clinical cases of where it's worked for me, as well as clinical cases where it has not worked for me. Now, it's always nice to show the cases that work very well, but I've had failures, I've had complications, and that's probably because I may have been stretching the limits of the material a bit too far, right? So this first case, this is a 40-year-old female. She came to me with what was previously known as localized aggressive periodontitis. So now staging and grading of periodontal disease has changed. Okay, so she had undergone complete non-surgical periodontal therapy, was completed, non-surgical debridement was done, and she was left with an 8mm probing pocket depth on tooth 4-2, the distal of 4-2. Okay, so that's the tooth right there. Unfortunately, we have already lost the papilla because of the destruction. So we've got an 8mm pocket, and you can see a V-shaped angular bone defect. It seems to look like a two-wall defect. And based on the probing depth readings, we probably had an intact lingual wall, right, but no buccal wall. So in this case, so that was the incision. Now this is still not minimally invasive yet, because this is one of my first few cases I was doing. And of course, I didn't want to open a flap as big as what I would do with GTR procedure, but the vertical incision was there so that I could gain access to the defect. So upon opening, there was a defect, right? So once the granulation tissue was cleaned out, the roots were plain, as would be the normal protocol for periodontal regeneration. That's the defect that we were left behind with. Okay, so it was a significant defect on the distal of the lateral incisor. Okay, here, one of the things that I noticed was, this is probably, you would get used to this as you're using EthOss. You need to control the breathing a little bit so that you put it in, you can dry the material well. So here, once the material is hydrated, now the good thing is you can actually mold it and shape it a little bit. Okay, with the idea of never overdrafting. Okay, so I've learned that the hard way. Alright, so you put it in, you dry it. If you're not happy with the shape, you can always wet it a little bit and dry it up again. Right, and here, so dry it for about 5 to 6 minutes, or longer if you want to. And this is where it sort of hardens inside it. Right, so here it hardens and then the suture it doesn't move around. Okay, so suturing was done very simple double sutures. I use a dressing as and when needed. And this is 1 week post-op. Now, one of the findings that I always noted with surgeries when I was using EthOss was that soft tissue healing was really good, right? I don't see any inflammation along the incision margins, and soft tissue always looks very nice. I'm assuming this is because calcium sulfate is very tissue friendly, and it has the antibacterial effects as well. So this was at 1 week post-op, and this is 1 year. So pocket reduction, now the pocket was 3 millimeters on the good soft tissue healing with very minimal recession, right? Unfortunately, recession is a consequence of doing surgery around teeth, whether it's GTR or OFT, unless if it's not a recession covered surgery, we do end up with slight recession. It's just that how much the recession is there. It's less with GTR, and it's even less when we have minimally invasive surgical techniques. So what's more interesting is what we see in the X-rays. So this is a pre-op EA. So you can see the defect right there in circle, and this was immediately post-op. The graphs completely filling up the defect. Now, for EthOss, as you know, it's 2 different materials, and those materials have got different resorption profiles. Okay, calcium sulfate, I think, resorbs between 8 to 12 weeks, and then Biphasic takes a little longer, 6 to 12 months. So what the next period after 2 months, I noticed that it became less regular, exactly what Dr. Stowe told you, right? And my first thought was, oh no, it's resolving too fast. So the stereotype came back, right? What all the comments that were previously said, it's resolving too fast, I'm probably just gonna lose it. Okay, so we left it to heal, and this is 1 year post-op. So the radial opacity came back. So at this point is where most of the calcium sulfate component is gone. You're left behind with a very porous beta TCP scaffold. And that's where the angiogenesis cellular infiltration comes in. And that's why it actually upregulates post-bone regeneration. And in this PA, you would probably be very hard pressed to differentiate at which site the regeneration was done. It looks an actual bone. It looks same as the appearance on the bone on the tooth next to it. Okay? So this is what surprised me, and that's why I started using it more and more often. Now, second case, this is a 47-year-old female. This is a posterior tooth now. I'm sure you all can agree, doing surgery, posterior part of the mouth is always more challenging, right? Especially in the mandible when the patient's tongue gets in the way and the saliva pulling around the area we want to do surgery. So in this case, it was a lower molar, the 4th quadrant. So again, a 6 millimeter defect on the mesial of tooth 4-6, and that's the defect that we can see right there. Right, also appears to be a 2-wall defect with an intact lingual wall. So we opened it up and cleaned it. In this case, it was a combination defect. Coronally, it was just a 1-wall defect with just a proximal wall intact, and apically, a 2-wall defect. So this was sort of like a less retentive defect to begin with, right? So compared to the previous case. In the previous case, we had more or less quite an intact single wall, so it's a 2-wall defect, it was retentive. I mean, of course, the best is always a 3-wall defect, but in periodontal disease destruction, we hardly get that, right? So in this case, it was a 2-wall defect, but bear in mind, there were no, apart from elevating the interproximal tissues to the lingual aspect, there were no other incisions on the lingual aspect. Right? So on the lingual aspect, right behind the suction tip, there was actually a soft tissue, intact soft tissue wall, which was not reflected. Okay, so that sort of acted as a barrier at the back. So again, EthOss was molded and shaped and dried, so to maintain the shape in there, and acid chlorine. This was 1 week post-op. Again, excellent soft tissue healing, very little inflammation in and around the incision lines or around the sutures. And this was 6 months post-op. Thankfully, there's almost no recession, very good soft tissue healing, and a 3 millimeter probing pocket depth. Similarly, as the previous case, this was a pre-op photo, immediately post-op, and 1 month post-op, again, much less radioactive than immediately post-op. So again, I thought, okay, is it going to go? Is it going to stay? Okay, but then at 6 months, This is what we have. Right? We are very nice still. Okay? And looking more and more like post-bone. We repeat the patient again at 2 years, 4 months. So this was the second question in my mind. Since EthOss was new in Malaysia, we had little data in terms of treating periodontal defects. Will the regenerated bone last, or will it just disappear? Now there is a standing problem with GTR. Sometimes after 3 years, 4 years, we tend to see pockets redeveloping in sites where guided tissue regeneration was done. It could be a recurrence of periodontal disease at the site. Maybe the patient was gone without any supervision or no maintenance for a while, and this recurred. So we still had that worry as well with this new material. But so far, it's not actually really been that long, since 2018 till now, so I don't really have very long-term data. But some of our patients are coming up to 2 years, 3 years, and when we review them, we find that the bone is holding well. So is the soft tissue already. Okay? Now, so that entire surgery would have took me about half an hour to 45 minutes. Now, if we compare that to what I used to do, so this is what I used to do. Similar case, lower 6 as well. And you notice the extent of the flap, almost from the middle of the 7 right down to the midpoint of the first premolar. Was a much larger flap, equally on both sides, buccal and lingual. So this would definitely increase healing time, increase patient mobility, increase chairside time. A lot of time was taken to get this shape, right? So it's I'm good at it now, but in the first couple of years, it was a real struggle. Half an hour, 45 minutes just to get this, just to make sure that it hugs the contours of the nasal surface of the 6 and the distal of the 5. So very time consuming. Okay, but a tried and tested method, and it works. Okay, so this is the comparison. Right, so in the length of time it takes, as well as the invasiveness of the surgery. Now, I've also tried using EthOss in furcation defects. As we know, furcation defects are tricky, right? Periodontal regeneration is more predictable in mandibular furcations compared to maxillary furcations because the anatomy of the defect is really difficult to clean. When you have a grade 3 furcation defect, it's really difficult to get instruments inside and to make sure that we have actually thoroughly debrided and disinfected the root surface, right? So it's a little easier in mandibular bifurcations. So this is one case, 4-7, where the patient turned up with a periodontal lesion, and my restorative colleague completed the RCT as best as he could, and we were left with what seems like a coronally true and true defect, but more apically it was a grade 2 furcation defect. So when you open it, there it was. So that's the defect right there. So again, same simple protocol, right? It's always simple with EthOss. So we hydrate it and we put it inside, dry it up, make sure it's stable, and then get the soft tissue cover up. So again, so here it is, everything covered up. And that's pre-op, immediately post-op, and 3 months. Of course, it's impossible to consider regeneration right up to the top of the furcation, but where the grade 2 furcation ends, we managed to regenerate up to that point. Okay. Now, once I completed a few cases like that, then I started trying to go into less invasive surgeries to see whether the minimally invasive surgical technique which is proposed by Cochlear, does it work together with EthOss? So this case is another 39-year-old male, 7mm probing pocket depth on a nasal of 1.4. Because in this case, surgery was a little easier, there was a big space, lots of soft tissue, very easy to open. So then that's the defect right there, 2-hole defect. And a minimally modified papilla preservation technique was used, just a reflection of papilla on both sides and nothing more. Okay, so the defect was debrided. So what we have here is an apically 3-wall, coronally 2-wall defect, which is on the most, very retentive defect. So putting in the EthOss inside and letting it stay is not a problem. So the EthOss is grafted in, molded, shaped, and dried, and passive primary closure. Okay. And this is 1 week post-op. Again, very nice soft tissue healing. His oral hygiene could be a little better, and we worked on that, and he has improved. And the soft tissue is very well supported by the graft. And this is at 18 weeks post-op. Recession now measures at 3 millimeters. Okay? So this is a pre-op X-ray. Immediately post-op, 18 weeks, and now 2 years. So the bone is still holding well. Right, so it's nice to see cases like this come back, and we know that the bone, so post-regenerated bone is actually holding very well, as it should. Right? Now, what I'd like to share with you next is typically what I do. It's a short video, typically of what I do now in my practice when it comes to treating carbon defects. Now, this is an elderly gentleman, 61 years old, again with an endoperic lesion on the upper central incisor. The initial pocket depth was 12 millimeters. So again, a colleague of mine completed the RCT, and this was 5 months post operation, and we still had a significant defect. So in this case, we had good soft tissue. There was a very wide interproximal space, and it was a good case to actually use the minimally invasive surgical technique and see whether it works. So this is a short video. So a papular preservation technique was employed to make sure that we minimize the visual distal extension of the flap, as well as the apical coronal elevation as well. This provides for a more stable wound site, and it minimizes the amount of recession that we get post-surgery. So let's speed up the video a little bit, save some time. So once the labial flap has been elevated, all that needs to be done is a resection of the papilla from the underlying granulation tissue so that we can actually push the papilla to the belly. And beyond that, there are no other incisions on the palatal aspect. The granulation tissue occupying the defect is then pirouetted out, and of course the roots are sealed and cleaned as well. So that's the defect that you see. It's a deep two-wall defect, about 8 to 3 wall. And this is just a video of how I use EthOss. So in this case, I tend to dispense EthOss into a lollipop because I don't use the whole syringe, right? At most I use like maybe 1/4 of the syringe. So I dispense it up into a sterile telepot, mix it about, and then put it into the defect. I use amalgam carrier as well sometimes. Or otherwise just a parasol elevator will do. So once the bleeding is adequately controlled and defect, that's when we start putting it in. So in this case, since we can't access the entire length of the defect after the apical part, what I sometimes do is put in layers of EthOss. Put it in right in the way, get a little stable, and then put in more layers. So again, the key here is not overgrafting. Since there is no advancement of the flap, no scoring of the period, we're not able to advance the flap. So just a matter of putting in just the right amount of graft material and then suturing it passively. So once enough material is gone in as usual, you put in a dry gauze, dry it, get it set, and then begin suturing. So there's the graft, nicely set and covering the defect, contoured well, and again not overgrafted, and just one single oral suture. That's it. Nothing. Nothing else. So this actually helps healing very well. Patient has very little discomfort. In this case, it's a clean contaminated surgery, so I don't prescribe antibiotics as a routine, just painkillers. PTFE sutures work really well in these kind of cases. Let's just be struggling to get the loop in the right place. And that's it. That's it. So from start to finish, half an hour, or 45 minutes. Right? So very small, very comfortable surgery for the patient. Now this was done not too long ago. So we just had the 3 months post-op review. So again, excellent soft tissue healing. A little bit of clefting there, but that will eventually fill up. But now you can see that, again, the same appearance. It looks less radiopaque. Right? But then you can see that the particles of beta PCP are still there, still holding. Alright, so we'll be seeing him again for 6-month review and then further on for another year. Okay. Now, so that's actually the kind of work that I do now in my clinic with EthOss. I have not, since 2018, I have not used a membrane for periodontal regeneration. It's all been EthOss. Yes, I've had failures. That still occurs even if you use CTR, right? Not all surgeries are successful, but it's more comfortable for my patient. It's better for my back. I'm not hunched over the patient for too long. Okay. Now, apart from treating periodontal infrabony defects, I've also used EthOss to treat periodontitis. Right? The idea of a graft that is bacteriostatic is actually very interesting. As you know, periodontitis lesions are more aggressive compared to periodontal lesions, right? And we usually end up with a crater defect around the implant. And as you open the defect, there's a lot of ventilation tissue and everything bleeds a lot, right? So this is a case of a 76-year-old male. The usual complaint always comes in, you get an implant in, it was maintained for the first 2 years, and then it was just left open. Okay? Now, periodontitis is becoming a growing issue. Implants are, the number of implants being placed worldwide is growing at an exponential rate, and eventually we will see more and more cases, even cases that are well maintained. It could be as simple as periodontal mucositis, but it could be as bad as periodontitis as well. Right? Even in some of my own cases where I place the implant and I maintain the patients, sometimes they come in after their 1-year review, come in with mucositis. So although I can control all the local factors in the mouth, I still can't control the patient's behavior and habits. So it does happen. So this was a case that was referred to me. No follow-up for 6 years. Now, as we have a new classification now by from the EFP group, and they've come up with brand new classification for periodontal diseases. Okay, and it's worth to check out. So in this case, we had pocketing exceeding 6 millimeters with suppuration and profuse bleeding, and this is the radiographic appearance. So we have bone loss on the medial aspect of the implant, and as well as some bone loss on the distal aspect of the premolar. So lesion took both out. And this is what it looked like locally. Periodontitis lesions, unfortunately, many basic surgical techniques do not work because you tend to get a crater defect around the implant. So you just have to open it up and clear it out nicely, right? Now, this is what we found inside. Now, this piece of material here was actually infected bone graft, right? I'm not sure who placed it in. It was placed in some time ago, and the material was there. It was stuck on the implant surface, was infected, so it did holding out. Now, in periodontitis lesions, I think equally as important as the biomaterial being used is the treatment of the implant surface, because we're trying to re-osseointegrate the implant, right? Proper disinfection is vital, mechanical and chemical, depending on what we have in the clinic. So once that is done, it's usually quite predictable. The ideal situation here would actually be to remove the crown, Alright, submerge the implant, allow everything to heal nicely. But in this case, unfortunately, this was a cement retained crown. The patient could not afford a new crown together with the components that come with it. So this was the way to go. Alright, so we'll continue to clean it up. So again, same. Once everything was clean, same protocol. It was hydrated, packed in, dried, and this is what we had 5 months post-op. Alright, very nice soft tissue. Yes, we've lost a bit of the buccal contour, was expected. Pocket depth is now less than 6, no BOP, no radiograph. And what we have on the radiograph, this was immediately post-op, close to 6 months post-op. Okay, looking more and more like post-op. And we recently saw him again 1 year, 8 months post-op. Maybe a little bit of residual graft material, but what was surprising as well was we managed to regenerate the bone on the distal of the premolar. So a 2-in-1 thing. Okay. So this patient is stable, is happy. Another case, in this case, was less common, retrograde periodontitis. The implant was placed by a colleague of mine after the tooth was taken out because of a long-standing periodontal infection. Once the implant was placed in, patient came back after about close to a year, 8 months, 9 months, and he had a discharging sinus on the apical part of the implant, just over the apex of the implant. So here again, we opened up the flap. Just a very small window, just enough to get titanium instruments in to debride the surface, as well as any form of chemical or mechanical debridement. And then EthOss packing. So one of the advantages of EthOss is value size is really small, right? So you can actually really pack it in nicely into the defect, right? And then close and allow to heal. So this is pre-op and 3 months down the line. So everything's healed very nicely, patient's happy. Okay. So again, it's been successful up to this point in treating periodontitis as well. Now, apart from periodontitis lesions, periodontal inflammatory defects, I do use EthOss around implants, or more often in extraction sites, just as what Dr. Scott has mentioned. In treating extraction sockets. Okay, so doing socket preservation or alveolar ridge preservation. Okay, so this is a case of a 26-year-old female. 1.5 was extracted, and she wanted an implant in. So of course, the first thing was to rebride the entire socket, graft it with EthOss. And I also use collagen fleece sometimes to cover it and allow for secondary bleeding. But in this case, we opted for a free digital graft to cover the socket opening, right? So a free digital graft done was covered socket opening. It works well with smaller sockets. I would not attempt this on molars because the graft would probably die before it covers the defect. So in this case, it healed very well. This is about, if I'm not mistaken, about 5 months post-op, and that's a PE. So very nice healing. And after this, implant goes in with no issue. All right, we have enough bone, enough the buccal contours. So here, implant goes in well. Again, the cervical healing abutment to improve the buccal contour a little bit, so that works very well. All right. Now, the next one I would like to share with you is where I have pushed EthOss maybe a bit too far, trying to use it in cases where it doesn't work so well, or what happens when there are complications. Now, the main complications, the most common complication for periodontal regeneration is membrane exposure, because we're dealing with interproximal soft tissue, right? Fortunately, we Asians have got a thinner gingival biotype, right? It doesn't hold up so well sometimes, it's a surgical trauma, right? You tend to have wound descents, tissues fail, become bruised. So, this case was actually done by a Perio resident who was attached with me. It was a middle-aged female, male, 236, again, very typical, infrabony defect on the nasal aspect of the 6. So same protocol, namely based surgical technique, where we open it up, small flap on the buccal, interproximal soft tissues elevated to the lingual side. Everything cleaned well, grafted with EthOss, and closed. In this case, it was one horizontal mattress and one simple interrupter to approximate the margins. Okay, so the patient went back after that. Unfortunately, a week later, he came back with this. So this is early wound exposure. Now, if this was done the conventional way, with a xenograft, allograft, or membrane, what you see now is the exposed membrane. And those kind of cases, it's actually quite easy to manage, provided there was no infection. As long as the collagen membrane is not infected, the graft is not infected, all we needed to do was to protect the wound site till the gap bridge is over. Okay? So in this case, it's a bit difficult to say why it happened. Maybe soft tissue handling wasn't very ideal. The papilla seems to be a bit bruised. Maybe the patient didn't follow instructions. Difficult to say. So in this case, it's exposed. We don't see graft material inside. So this is actually one of a few failures that I've had. What happens is, of course, when there is early exposure of EthOss, it gets hydrated again and starts leaking out. Okay? There's no soft tissue closure. Okay? So there's no membrane to protect it. Okay? And this is what happens. So we left it to heal, no choice. Right? So it's just secondary healing, left it to heal. 9 months later, there's more recession than we would likely to have, but they will still pocket reduced to less than 1. Now, if you look at the X-ray, that was pre-op, immediately post-op, so right up to the lingual wall, but this is what was left 9 months. So bulk of it actually leaked out. Some of it retained, surprisingly. The apical part of the defect actually retained, but most of it actually leaked out. Right? So this is one of, I think, in terms of periodontal surgery, one of the things that we have to keep in mind. Right? In terms of complications, it may not fare as well as the conventional surgical technique with a membrane. Okay? So soft tissue handling is important, the skill is important as well. Okay? Now, the second case is a case where I learned not to overgraft. Right? So as mentioned, never overgraft. Doesn't work. The graft may collapse on itself. Right? There is nothing to actually hold the graft up. So one of the things that you've seen with the previous lecture, using titanium cages to actually hold the membrane in, EthOss does need some sort of form of support if you're going to do bigger grafting. Okay? So this is also a Perio case. 56-year-old male, again, endoperio lesion on the lateral incisor. And initial pocketing was 30 millimeters, and the tooth was actually breakthrough mobile. To begin with, this tooth was poor prognosis. Okay, we offered to take it out and then offer some form of replacement, but he was insistent that he needed to save the tooth. So after the root canal was done, about 5 months, bone loss looks like it extended beyond the apex. And it did. So in this case, I've already anticipated I had to open a bigger flap, so we did away with minimally invasive surgery and actually just did a big flap, raised the whole thing up, and that was a defect. Right? The tooth was splintered halfway through to regain stability. So at this point, again, we told the patient that, okay, it looks like it may not survive the surgery, it may drop, but it was willing to take a chance, so we did it anyway. Okay? So the effect was all the way up there. So you notice it's basically a retentive part of the effect just about over the apical part, right about there. Okay? But old habits die hard. This was definitely overgrafted. So when you have the EthOss in your hand, it is difficult not to overgraft. You have to keep that in mind. So this is a hard lesson learned. So I grafted way beyond where the retentive part of the defect was. Okay, so it was grafted and sutured, and hoping that the soft tissue stays put at that level, which of course it didn't. So we lost him for follow-up for a while because of the movement control order. Everybody's on lockdown. So he came back 14 months post-op, and yes, there is significant amounts of soft tissue collapse. But the pocketing went down to less than 5, of course, accounting for the recession as well, and no mobility. It was firm. Okay? He learned to accept that huge space between the two teeth. He was happy he had the tooth. But all that excess material went to waste. Right? It just disappeared, and nothing grew. So if you look at the x-rays, this was baseline, and this was 14 months post-op. So all we could regenerate was the part of the defect that could retain the graft, when I grafted right up to this level. So grafting doesn't work. Okay. So this is where I learned that just put enough in just to cover the defect up till the highest bone wall, and we leave it alone, and suture it close. All right. Now the next case, the last case I'd like to share. This is more to do with implants. This guy had a long-standing infection on the lateral incisor, and it was extracted somewhere else, and a very severe defect. We wanted an implant to replace it. Placing an implant immediately was not my plan to do. I wanted to rebuild the ridge and then place the implant with no issues. So once the flap was elevated, here you can see the huge defect. We have partial loss of the palatal wall as well, huge defect on the buccal, huge greater defect. So in this case, I used a single component synthetic graft. Now this was before EthOss was introduced in Malaysia. So this around about 2016, I did this. And I used HA, harvested some autogenous bone from the surrounding area and grafted it. Okay, moving over. Of course, all other preparations were done, decortication of the surrounding bone, and it was grafted in. The membrane was covered, stabilized with pins, and allowed to heal. And this is what it looked 8 months. So we left it for a while. Patient couldn't make it for some disappointments. We left it. 18 months went very well. It looked really good. Good soft tissue, good ridge width. CBCT looks really good as well. It should not have been an issue to place an implant in. So he came in for his appointment to have the implant placed in. And when we opened the flap, this happened. The entire chunk of bone just fell. Right, so it was encapsulated. There was some integration around the periphery of the defect. The rest of it just fell out. Okay, so then I can believe what the Perio 2000 paper said, that you could do better than using synthetic graft, and in this case, single component synthetics. Okay, so I already promised the patient that he's going to have an implant on the day. So we discussed with him. This was a bit of a special case. This guy is my next door neighbor, so he knows he knows where to look for me if things go wrong. So we discussed it, and I said, okay, why not we try it? Okay, put the implant in as the implant. EthOss has something to hold on to, and then graft over it. Okay, but this is still was early stages. So this is one of the first cases I did in 2017, end of 2017, early 2018. Okay, I'm still learning how to handle EthOss graft. So it's a nice fit. The sutures, got the implant in, one dome suture across the support. In hindsight, I probably could have placed another one or something else to hold the graft material in. And then EthOss was packed over. Right? Maybe a little bit overgrafted. Okay, so on the buccal set on top of the implant as well. Now this is a case that I'm not proud of. Alright, I would have done it a different way if once I'd seen the outcome. It's a case I use to remind myself not to get too cocky when I do surgeries. Alright, to make sure that you have to respect the host, respect the bone, and make sure you know what the limitations of the biomaterials are. Now that's 6 months post-insertion. So what was very nice to see was there was bone grown right over the implant. Okay. So first thing was, I was very surprised to get this amount of bone over the implant, especially with EthOss. So once we uncovered the implant, placed it, but when we uncovered the implant, what I did notice was the coronal part of the implant, the bone was very thin, really thin. I think less than 2 millimeters, right? Because judging from the defect that you saw on the last slide, we had at least 4 threads, 5 threads still exposed. Okay, so I think with the volume of EthOss that I placed over the implant, it would have been more prudent to place something, maybe more dome sutures or something else to hold the graft in. Okay, so as expected, I was expecting that coronal bone to actually be lost once the transmucosal attachment is connected. So you get a typical funneling defect, and once the crown was issued and reviewed, yeah, we lost a little bit more, but the rest of it was all covered. So not one of my proud cases, but in hindsight, I would not have done this again. I would just have rebuilt the ridge or used a combination of xenograft with growth factors and autogenous bone and really building up the membrane. But it's surprising of how much EthOss could regenerate. So that was very surprising to me. Okay. So it probably would have done better with Thai mesh. So this is one of the cases where I think I stretched the capabilities of EthOss a little too far. Okay. So it's a good material, but it has its limits. So that is what it was before and what we have now. Okay. So with that, my personal thoughts about EthOss in terms of periodontal surgery, it does help reduce surgical time. To me, it's predictable. It's small to moderate defects around teeth. It works very, very well with minimally invasive surgical techniques where you don't have to open the flap too big and the graft can stay in the defect as you suture it up. But it has good soft tissue response. When compared to the conventional guided tissue regeneration, it maybe doesn't do too well when complications arise. Like I said, the main complication now is early wound exposure, right? Because EthOss unfortunately leaks out a little bit, okay? And probably with larger defects around teeth, some sort of support needs to be placed for EthOss to hold on to, okay? And with that, I thank you very much for listening.
Oh no, I'm gonna try and place my phone. Okay, charge it up. It's very fast. I'm just trying to delete my phone. See all the information. And I need to go to the police station. But there's some shops.